Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Welcome back to episode 2 of our series on heart disease in women, risk, prevalence, and diagnosis. Joining us again is Dr. Joshua Weinstock. He's our subject matter expert. Welcome back.
Thank you. Pleasure to be here.
Great to have you. Last episode, we talked about some really important things when it comes to women's health and heart disease. We talked about risk factors and how they present and diagnosis, and we're going to continue that conversation now. So, Dr. Weinstock, referring back to estrogen, we talked about estrogen in the first episode and how it can have a protective factor with women in heart disease, and solely responsible, from what I gather, or is it partially responsible for the fact that we generally don't have issues until about 10 years after men, right around the age of 65. Is that correct?
In general, yeah, women have some degree of protection from hormonal protection from estrogen during the childbearing age up until the point of menopause, and the postmenopausal years that kind of drops off. Yes.
Okay. And so let's talk hormones a little bit here. You stated there were more at risk after menopause, like you just said, but what about pregnancy? Anything that fluctuates the hormones, is that a risk too?
Sure. So actually, pregnancy itself is a very vulnerable period for females, and a lot of things that can, unfortunately, a lot of the problems. There can be a lot of cardiovascular things that can complicate a pregnancy.
Sure.
Things like preeclampsia, things like gestational diabetes, all those cardiovascular things that can affect a pregnancy actually are a setup not only can they be dangerous during the pregnancy itself, but actually increase the risk of cardiovascular disease for those women later on in life.
Wow.
And so, it's a vulnerable period of time. And, it's also important that, when taking a history and that patients understand that they need to be a little bit more careful. And as providers, we need to be aware of those things.
And if there's an increased risk with pregnancy, is it multiplied by having a genetic factor or family history?
Yes. I mean, I would say the more kind of strikes you have,
right.
All those things can kind of compound. And so, if you already have, diabetes, and now you have preeclampsia and maybe have a family history, certainly all those things in combination can, portend a bad outcome later in life. And so, again, going back to prevention and disease mitigation, these are all things that, we want to be aware of so that we can lower the risk for our patients.
I wanted to also ask you about spontaneous coronary artery dissection, or SCAD for short. Where do women stand when it comes to that?
SCAD, spontaneous coronary artery dissection, is actually a very interesting topic and very pertinent to our conversation here, in the sense that it's a disease that actually predominantly affects women. So we see it most commonly in women. It can affect men, but mostly women. And when it affects women, it actually tends to affect younger women.
Really?
So we tend to see it in women in their 40s and 50s. So and it can be very concerning. So spontaneous coronary artery dissection, actually, what that is a pathologic process whereby the coronary arteries are going back to your anatomy, the coronary arteries are the blood vessels that come off the aorta and feed the heart tissue itself, so that the heart, can do its job in pumping blood to the rest of the body. When you disrupt the coronary artery, the intimal layer of the coronary artery, and cause disruption of that intimal layer so that you cause what's called a false lumen or a false channel down that artery, you can actually impede blood flow to the end organ. So impede blood flow to the heart, and actually the symptoms can mimic a traditional heart attack that we see from patients who have ruptured plaque or from atherosclerosis or thrombus, another thing. So the symptoms, patients can develop chest pain, kind of a lot of the same symptoms, and it can be, it can be worrisome because when the blood is not flowing down that normal coronary artery, you can ultimately have areas of infarction where the heart is not getting nourished adequately, and so it can be very problematic, and it's difficult to manage, and it primarily does affect. We see it mostly in women, and it tends to affect women early to midlife, like 40s and 50s or so. Why it occurs is a little bit, there's not exactly one specific way that it can occur, but it's thought that women, especially women who have had recent childbirth or kind of in that pregnant or in that postpartum period, recent childbirth, due to the hormonal shifts associated with pregnancy and due to the demands on the cardiovascular system with that period of time, may be a little bit more vulnerable to having, disruption of the blood. People who have underlying connective tissue diseases, who have underlying vascular issues, tend to be at greater risk. And so that's an important topic, because I think, a lot of people aren't aware of SCAD, but we do see it. It's not all that uncommon. And in fact, for women who present with an acute coronary syndrome before the age of 50, SCAD, the statistics are about a quarter of those patients will be found to have SCAD.
Wow.
So it's not, for providers who work in a cardiology setting, this is something you will see. It's not all that rare.
That's interesting. Yeah, it's not something, it wouldn't be your first go-to when someone comes in and presents like that. But that's excellent information. Now, we did talk about risks quite a bit in the first episode, but I really would like to go back to those. I was thinking that there was something that I wanted to ask you related to risk, and or just have you clarify, because I think most of us know that it is a risk. But there's illegal drug use, like heroin or cocaine, makes people more susceptible to, right? That's
Of course, yeah. Cocaine can cause a coronary vasospasm, and that can it can induce spasm of the coronary artery to the point where when the artery spasms, it can cause a heart attack, can cause myocardial infarction. So that's something we see. So, all those illicit substances, things like cocaine and heroin, they're all bad for the heart for sure. Cocaine especially is a bad actor.
So let's talk about some of the risk factors that we spoke about. So smoking cessation, are there any methods of quitting that are more successful than others that you've found?
Sure. So it won't come as a surprise to anybody that smoking is bad for the heart and the cardiovascular system, and in general, bad for the body. So we need to work with our patients on, getting them to successfully cut back and quit smoking to lower their cardiovascular risk. In fact, people who smoke are anywhere from 3 to 6 times at increased risk for coronary disease. So it's a tremendous increase for smokers, and so we have to work to help them. It's easier said than done for anybody who counsels patients on smoking cessation. It's a challenge, and it's certainly an addiction. And so patients, and providers need to work together to build an alliance to help them successfully quit. For some patients, they're able to do it cold turkey, but the overwhelming majority are not. And so things like nicotine replacement therapy, patches, gums, all those things, are in our armamentarium to use. Working with behavioral healthcare providers and counselors and therapists is a big role. And lately, we do have some pharmacologic options. There are medications like varenicline and bupropion that, you'll see patients on in an attempt to assist them with quitting smoking. The medication options are things that, patients need to discuss on an individual basis with their providers, because they do have side effects, and one in particular, has a black box warning for things. So you need to be aware of the patient's history, and it kind of has to be an approach that's tailored to an individual with an understanding of their past medical history. But for me, I think the approach that works best is actually not any one of these things. These things all work best, I think, in combination.
Sure.
So, we need to work with our patients when we're addressing them, making sure they understand their disease process and their increased risk, but they also need to work with healthy ways to cope with, their addiction, perhaps a medication, perhaps, a therapist. When you take a multifaceted approach like that, I think patients tend to be more successful.
Excellent. That's interesting about Nicorettes or nicotine replacement in a sense, but I guess it's more the smoke that causes the vasoconstriction and all of the side effects, or is the nicotine actually okay?
So the nicotine itself is not that it's okay. It's in itself is not really the best, but it's better than
Right.
smoking. You're basically inhaling hundreds of thousands of different particles. You're not just inhaling tobacco, you're inhaling
Right.
a lot. And it's tough to say on an individual with those thousands of chemicals, which chemical is doing what.
Sure.
But we know that, if patients are able to cut back or, quell some of their cravings with nicotine replacement, that is a better option than picking up a cigarette. But ultimately, the goal would be to get them off of nicotine supplementation, and ultimately to quit.
Right.
Yeah.
Excellent. Good. Now, we mentioned physical activity. A sedentary lifestyle is definitely a risk. Is a simple walk daily enough, or should we be getting our heart rates up as much as we can?
That's a great question. So it is important to be active, physically active. The American Heart Association actually has some established kind of guidelines on, what level of physical activity is adequate. So, according to the American Heart Association guidelines, their recommendations suggest that patients should be getting a minimum of 150 minutes a week of moderate intensity exercise. And when they say moderate intensity exercise, what they mean is something that gets your target heart rate up to anywhere from about 50 to 75% of your target heart rate, which is based on your age. If you can, and the formula for that is 220 minus your age is how we get to that target heart rate. So if you can get to 50 to 75% of that target heart rate, 220 minus your age, and you getting your heart rate up for 150 minutes a week, that should be, what we all strive for. The more physical activity in general, the better. They also do say that if you exercise for at least 75 minutes vigorously, so for an activity that gets your heart rate up from above 75%, closer to 75 to 85% of your target heart rate, that, 75 minutes of vigorous physical activity is what, so it's either striving for 150 minutes of moderate intensity activity or 75 minutes of more vigorous activity. So, when you break that down in terms of counseling patients, what I like to say is at least 30 minutes, 5 days a week gets you to 150 minutes. So really heart rate does matter. So it's,
okay.
Taking a walk is excellent. You want to be physically active. So I wouldn't frown upon that by any means, but I think we need to work with patients to, find ways to, be physically active and, get their heart rates up.
And what is a normal weight for the average woman, depending on height, of course, but BMI even? Where should we be?
Yeah. So it's tough to say what, the quote normal weight or what, but I think when we talk about BMI or body mass index, what we're really looking at is their patient's body mass index to their height. So when we calculate a BMI, what we're really looking at is a patient's body weight in kilograms divided by their height in meters square. And you can kind of put patients in certain buckets as being, underweight, being at normal weight, being overweight, or being, obese at the other end of the spectrum. What's considered normal is anywhere having a BMI between 18.5, so 18.5, up to the cutoff is really like 24.9 up to 25 is where we really draw the line. So 18.5 up to about 25 is considered a normal BMI. When you get up to 25 to 30, you're in that kind of overweight category, and then above 30, obese. And anything under 18.5, you're considered to be underweight. But the BMI as we know it, is an imperfect tool. It doesn't take into account how the weight is distributed. It doesn't take into account muscle mass. It's just, a body mass index. So it's good to look at BMIs on, we use it in healthcare, and it's good on a population level when you're looking at, large numbers and population level. But for an individual, it's probably not the best indicator of health, is what we're coming to realize, but it's still an important thing. And it's still, routine practice that we, follow a patient's body mass index.
When you said how the weight is distributed, is that relevant? Because we've often heard that if a woman is carrying it high throughout her torso, she's more at risk than if it's more hips. Is that true?
Yeah. So we do know that for men and women who tend to have more weight, distributed adipose in their belly and that tends to be worse. So there is some degree of truth to that. But another thing that also plays a big role is muscle mass. So like a bodybuilder, for example, it may be, maybe massive, it may have a lot of weight, but in fact, it's very cardiovascularly fit. And so again, it's tough the numbers are sometimes tough when you look at just a BMI in the absence of the patient. It's tough to draw a lot of conclusions there. You really need to look at the patient and then, use that as a starting point.
Yeah, great. In reference to diet, and I think everyone has a pretty good idea of what they should eat or what they shouldn't in most cases. But when it comes to teaching patients, do you have like a top 3 to stay away from and a top 3 to add? Not, I have to stick to 3. It's just, I'm just throwing it out there. But what are your big ones?
Yeah. So I think the big ones, and for me, I try to make it like as easy as possible for patients to understand. My big one, I think, is the things that are worse for patients. We know that fried and fatty foods are no good for coronary disease, but things like, in general, staying away from animal products. So things like, meats and high fat dairy, cheeses, those kinds of things are ways that, those are the kind of foods that we would want to stay away from. I think, unfortunately, in the American diet, we kind of have, a steak and consider that the main meal. I actually, in college, studied nutrition, and one of my favorite professors in college was had a doctorate in nutrition and taught, of course, and I still remember this years later, said that we should use meat as a condiment as opposed to the main, meal. And so his point was that, it's okay to eat meat in moderation. Try to pick leaner, cuts, things like chicken or fish as opposed to steak, and try not to make it be the main part of the dish. You can eat meat, but use it kind of as a condiment as opposed. So that kind of stuck with me. Eating meat here and there, like I said, is okay. But try to pick leaner cuts. So things like, chicken, fish, as opposed to the heavier things. The other thing I usually counsel my patients on is it's always better, I think, to eat at home with a meal that you've cooked because you know what's in there. Going out and eating out is fun, but you don't know really what's in the food that you're eating because you're not the one preparing it. And a lot of times, unfortunately, when you go to a restaurant, the meal, you're not in control of what you're eating because somebody else is preparing it. And so, eating at home, I think, tends to be healthier. I try to encourage my patients to cook themselves. And then, the other big thing is, try to minimize things like salt, trying to minimize things like saturated fats, and so those are the kind of the big things I talk with my patients about.
Okay, excellent. Thank you. Now, we're all living in a high-paced society now and, very results-oriented. So we sometimes feel like we're on a hamster wheel just running at the top speed. What are your favorite strategies for reducing stress for women or for anyone?
Sure, yeah. So stress is interesting because from an evolutionary standpoint, some degree of stress is actually protective and is good. And so stress can propel us to, make a deadline or, encourage us to study for a test. And when stress becomes disordered, is when, it's chronic stress. So it's stress that hangs around for long periods of time. And it's with this chronic stress that we do worry about the cardiovascular system. Chronic stress, we know, can cause deleterious effects on multiple organs in the body. It can weaken the immune system. It can cause physical stress to multiple organs. And so, when patients are under chronic stress, those are the ones that we need to work with in finding tactics to help them with, with their stress levels and ways to cope in healthy ways. So things, very much in vogue now, and things that, work for patients are things like mindfulness, yoga, meditation, things like, which can, other things that can improve lifestyle, like getting exercise. Those are things, counseling, therapy, whatever ways that patients can work to lower their levels of stress over the, long periods of time will be important and beneficial to the cardiovascular system.
Excellent.
Yeah.
So you wouldn't recommend alcohol as one of those stress reducers? 'Cause I know that's a risk factor as well, but how much is too much?
Yeah. So alcohol is an interesting topic because, I'm sure we've all seen stories where they say, a glass of red wine is good for you. And, that's actually been shown that moderate alcohol consumption can, have some benefit. And when we refer to moderate alcohol consumption, what they define as moderate is actually, unfortunately, it's different for men and women, but they label moderate alcohol consumption as 1 to 2 drinks for men and 1 drink for a woman. But moderate alcohol consumption is in general, considered to be okay and may, offer some benefit. But in cardiology and cardiovascular disease, we also do know that alcohol can be extremely bad on the heart, especially for people who, abuse alcohol. We see alcohol-related cardiomyopathies, unfortunately. And so it's a double-edged sword, and it's something where, again, it's tough to say whether it's truly beneficial, because we know that it can cause harm.
Sure.
And it can affect other organs. For alcoholics, can raise cancer rates and be toxic to other parts of the body. But in general, in moderation, a glass of wine a day, I think is okay. And some would say maybe offer some potential benefit.
Okay. Good to know. All right. Just don't have that second one. All right. Do you have any examples of any patients, like a female patient that's coming to you with chest pain or something that relates to what we've talked to today, that puts in a real life scenario?
Sure. So I do have one of my favorite patients from clinic who came to me. She was having some symptoms which had kind of been dismissed by some other providers that she had seen. They were a little bit, somewhat atypical in nature, but she was most alarmed by a family history. I believe her father had coronary artery disease and had a bypass surgery. And when she came to me as a patient, she had already had some risk factors for coronary disease. I believe she was in her early 60s and had uncontrolled hypertension, uncontrolled hyperlipidemia, we came to discover, and really hadn't seen a whole lot of doctors throughout her life, but wasn't feeling right. Her main complaint actually was dyspnea, not chest pain. She was short of breath and had somewhat of a limited workup, and basically it was told, that based on the workup that had been done, that, it was no clear explanation was given. So she got referred to cardiology, and she was somewhat scared to, I remember early on talking with her because of her father's history of bypass surgery. She was, very anxious about what the workup would involve. And we ended up doing a stress test as part of the workup, and it came back positive. And I remember she was, somebody who, that also made her even more uneasy about things. And we had to have a frank discussion about the indication of, for cardiac catheterization. And she was very worried. I don't think she knew a ton about cardiac cath at the time, and, had seen what her father had went through with bypass surgery and was worried that that might ultimately, be the path that she was headed down. Unfortunately, she did get a cardiac cath. She actually did very well with the cardiac cath. She was very nervous about it. I actually was there when she had it done. She came with her husband. We did find that she had a pretty severe lesion in her mid-LAD, so she did get stented. She got a stent to her heart. And that was actually around Christmas time a couple years ago. She was scared, but after going through the cardiac catheterization, she actually realized that, she had built up this fear and anxiety in her mind after seeing, the demise of her father to coronary disease. She went through the cath, we optimized her medically, and now, I've seen her many times in follow-up now, and she's has like this new outlook on her life where, unfortunately we did find that she had the disease like her father. Fortunately, she didn't need bypass surgery, and, one stent was the fix. But now she was somebody who we had a tough time working together because she was reluctant to take medications and other things. And once we found the disease and she realized that, we could work through this and that this wouldn't necessarily be, the end, we've worked very well in, optimizing her hypertension, her hyperlipidemia. And her husband, the interesting thing was that he hadn't seen doctors in years and saw what she went through. And now he's a patient of mine that I follow. And so that's one of the outcomes that kind of comes to mind, because there's a lot of apprehension that goes into the workup and diagnosis and treatment of this disease. But, we have good treatments nowadays. And so it's not always, a bad story. We can, take a bad story and work to, minimize and work to improve outcomes ultimately.
What a great story. It's perfect, actually. Yeah. Knowledge is power, I think, sometimes when people know what they're dealing with, but that's an excellent example. And it speaks to, as clinicians, that we really need to be aware of that anxiety that people have in these situations, because they don't understand a lot of times and what's going on. And it sounds really scary the minute you mention heart. So that was a perfect scenario. Thank you. Any final thoughts that you'd like to share with us regarding heart disease in women before we close?
Sure. So, first of all, February is Heart Health Month, and so it's awesome that we're dedicating time to this very important session. I would say as providers, part of the healthcare profession in general, we should all take this very seriously. As I mentioned, heart disease is the number one killer of both women and men in this country. And not, as I said earlier, not everybody knows that. And so saying that out loud and acknowledging that is important. So I think the take-home points are, to acknowledge that and to work, on some of these strategies that we talked about throughout the podcast to lower that. And I think that as providers, all of us can hopefully work to educate our patients, but also go back to our families and friends and community at large to educate, people on this disease process.
Excellent. Fantastic. Well, I got my red on for Heart Month, so we're ready to go. I've certainly learned a lot. There was a lot I knew, but a lot I do right, but there are always some things we can improve on. That's an important piece for all of us as women, for women who are listening to this, to, think about yourselves as well as your patients. Thank you so much for sharing your expertise with us, Dr. Weinstock. This information has been incredibly helpful, like I said, for all of us. So thank you for joining us. We really do appreciate it.
Thank you so much for the opportunity to be here.
And thank you for listening. Be sure to check out the many courses and podcasts available at elitelearning.com as you develop in your career. Like I said, knowledge is power. This is Leanna McGuire for Elite Learning by Calibri Healthcare.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.